welcome. My name's Nyrah. I'm a GP pharmacist and I'm your host for today's health show on British Muslim TV. Now, in today's topic of discussion, we will be talking about dementia, living with dementia, and how it can actually help support patients that are diagnosed with the condition. Now, I know dementia actually affects 1 in 14 adults over the age of 65, and it's becoming more common as a lot of patients age. Now, to talk about dementia a bit more in detail, I've invited a dementia expert, Dr. Eva, to talk a bit more about the condition. Hi, Eva. Thank you so much for joining us. How are you today?
Good evening, Nyrah. Thank you so much for inviting me. I'm very well. Thank you.
Brilliant. It'd be nice if you just introduce yourself to our viewers, a bit about yourself and what you're doing at the moment.
Okay, will do. I call myself a research psychologist because I combine practice with doing scientific research. And as you said, I mainly focus on people with dementia. And then from there, I mainly focus on non-pharmacological interventions, which makes us a very interesting pair, I would say, Nyrah. So anything that is not related to medication, we'll be looking at, like, what can we do to improve people's quality of life? Or their independence, or both of them, of course, preferably. And then I do a lot of work with mindfulness as well. And this mainly targets the people who care for those with dementia. I'm very much still in the stage of developing meditations and mindfulness for people with dementia as well. But there's a lot of back and forth between what kind of meditations would actually help someone with dementia, because it can be quite confusing as well. So in a nutshell, that's the main things I do. So I consult with carers of people with dementia, sometimes people with dementia themselves, work with professionals and research studies as well.
That's great. And I'm really excited that we will be talking about the non-drug therapies and, lifestyle interventions that we can take for patients with dementia, as, dementia is still a research condition. There's a lot of unknown causes, and I think with medications it's very limited. So it's really important we bring that mindfulness into the equation. And just to let the viewers know, I think Eva, you're calling all the way from Indonesia right now.
I am, yes, for sure. It is the middle of the night here.
Yeah, no, thank you so much for being committed and actually coming on the show in the middle of the night. Great. So let's kick start off the show with the questions then. It'd be great to talk about the basics. So what is dementia? A lot of people hear the term dementia. I know it's an umbrella term as well for a lot of other memory loss conditions. It'd be great if you can give us a bit of an explanation into dementia for people who might not know about it.
For sure. I think this is one of the most asked questions anyway. And it's usually phrased that what is the difference between Alzheimer's and dementia? Because it's often kind of used, it replaces each other, whereas it's quite distinct from each other, where, as you said, dementia is an umbrella term. And if I say it very briefly, it just describes memory loss or brain damage. And then there are around 50, the estimate is between 50 and hundreds of types or causes of dementia. And again, that already gets confusing, because is it a cause or a type? Well, quite often we don't know. So if we talk about Alzheimer's, we don't know if Alzheimer's causes the dementia or it is a type of dementia and there is another cause that causes all those brain tangles and the problems in the brain that represent Alzheimer's. So we wouldn't even know at this stage if the cause is something different or it's just that build up because of Alzheimer's. So dementia is an umbrella term. Alzheimer's is one type. I'll just call it a type for now of dementia. Then there's so many other causes as well. So it can be caused obviously by accidents, acquired brain damage. It can be caused by infections. UTIs are well known to cause then a delirium, and a delirium would be described as an acute dementia. If a delirium, and I'm sure you're familiar with this, Nyrah, if a delirium isn't treated well by the medical doctors, it may result in permanent brain damage. Whereas, in that early stage, it will be reversible. So there's all these steps, and same for infections. If an infection is treated well and timely, it will just result in maybe temporary brain damage, but then is reversed and the person goes back to their normal functioning, at least cognitively speaking. So there's so many causes of brain damage. And then, that confusion with Alzheimer's, which is an old age disease, which usually happens above the age of 65, then increases gradually in prevalence with age, but has a very specific change of the brain. It looks very specific. But then one of the challenges is, and I'm not sure if you want to head in this direction, but we can only establish the type or the cause after death when we're doing autopsy. So during life it is kind of almost it's not guessing. Medical doctors who are specialized in this, they have good knowledge, they will know the symptoms. But quite often it turns out that when the person has passed away, they did not only have Alzheimer's, but there was something else going on. So quite often then the diagnosis after death becomes a mixed type of dementia with at least one type of, so it's Alzheimer's or vascular dementia, Alzheimer's and Lewy body dementia, or even a third type may present as well. So it is so complex, and that does make sense because our brain is so complex.
Definitely. No, that was a brilliant explanation. Very clear, the basics of dementia and the different types you've kind of mentioned. And I think another type of dementia I know is Lewy body dementia. Now, because dementia has so many different variabilities and different types, are the symptoms generally quite overlapping then, or early signs of dementia are generally the same for all types?
Yeah, great question. I think actually the early signs are what help professionals to establish what is going on, because it does look a little bit different, but it's all in the details. And I think one thing to highlight is that dementia looks different for every person. And then within the person, it may look different every day. So it needs this careful mapping of what's going on. I work in aged care, I should say. So that's not where you will see a lot of Lewy body dementias, because one of the signs of Lewy body is that it actually starts earlier than an Alzheimer's. So you may be looking at before the mid-60s, even mid-50s, even mid-40s. And then the signs, the symptoms are different as well. So I think we're all very familiar with Alzheimer's, memory loss, confusion, forgetting names, events, forgetting people, forgetting that we've just eaten. I think that's our typical image, right, of dementia, whereas Lewy bodies may not impact the memory as much in the beginning, but more present as changes in personality, which can be subtle as well, or the onset of hallucinations and delusions. So it may look more like a psychiatric kind of issue, whereas, well, that's all interconnected anyway. And then there's your vascular, which follows from strokes or mini strokes, and that looks different again. I think the symptoms are in a way similar to Alzheimer's, but then it is where Alzheimer's is gradual, so gradual changes, gradual loss of function. Somebody with vascular dementia, the onset will be after an event in the brain. So any stroke, anything that blocks the arteries or reduces the blood flow to the brain. And then they may steadily function at that level for quite a while, until maybe another event, and then function drops again. And I just mentioned that combination, and you can see that if you would have both Alzheimer's and vascular, so you have that steady decline happening, and then an incident, and it would drop in function, and it stays at that level, but steadily declining again. So you can see what needs to be monitored to actually establish what's going on for a person.
Definitely. And you mentioned age before as well. I know the onset of dementia can vary depending upon your age group. So I think usually it's about onwards from 65. Is that the same for all patients, or is there a specific kind of age range where you would look out for dementia a bit more in detail?
Yeah, no, I think you're right that would be 65 plus, especially for your Alzheimer's dementia. But some of the other types may present earlier, and some of them may present much earlier. The youngest person I worked with was in her 30s, which was shocking for all of us. And it presents very differently. She had a prefrontal dementia, so the brain damage is mainly in the front and in the lobes, which impacts language and again the higher functions of the brain, so planning, and her personality was severely impacted. And then you get this situation where you place a 35-year-old into a setting with 85 on average, where there is the professionals cater for very old people, and then you have this really young woman, and she became super active. She was on her feet the whole day. She unfortunately presented with some aggression as well, so you can see the impact. This was really a snowballing effect on this ward, where she would agitate other people, not meaning to, of course, but just from what she was experiencing, she seemed to be looking for occupation or activity, and there was literally nothing for her to do. Now, I know there's homes now, and this is great news, that actually cater especially for people who are younger. There's a thing called young onset dementia that looks at everyone who is under the age of 65, because I felt with her, but that was also the type with dementia, her function decreased rapidly. So that's one of the things that the same with cancer, right? When you get it young, it tends to be a little bit more aggressive. And the other thing is their life looks so differently. So this lady also had.
I'm so sorry to interrupt you, but we'll definitely touch on this more in part 2, as now we're coming up to a break. I think I'll definitely want to touch more on how to cope with dementia, multiple different ways. So please join us again for part 2. I'll be talking to Eva a bit more in detail about how to live with dementia and online resources you can use. See you soon. Welcome back after the break. My name's Nyrah. I'm a GP pharmacist and I'm your host for today's health show. Now, in part 1, I introduced my guest, Dr. Eva, and we were speaking about living with dementia, the different types of dementia, and early onset signs of the actual condition. Hi, Eva. Thank you so much for joining us again. Brilliant if we go back into the dementia conversation. And I actually wanted to ask you, how is dementia normally diagnosed? So I know it's a very complex condition. It'd be great if you can just give us a bit more details on how would a doctor or a psychologist like yourself diagnose a patient initially with dementia?
Yeah, and this is quite a topic for me as well. Like there's many questionnaires out there. So usually how it works, there's not so much case finding where we would go out into the community. So somebody will come, usually after a while, because there's this whole at the beginning there may be a lot of denial, or the relative wants to come, but the person with dementia just is not ready. But at some point they will come. They will usually come together, and they'll start sharing about their symptoms. And for me, that would be the main part of trying to find out what is happening. But obviously there are standardized questionnaires. One of the golden standard ones would be your MMSE, the mini mental state examinations. But I now live in a very different country than where I started out. That questionnaire is not as applicable here as it is in the Western countries. There are some cultural issues. There are issues with being able to read and write, which is not as common here, or as not everyone here can read and write from that older generation. So, there are challenges there. Then brain scans can be done, but as I mentioned in part one, it will only give an indication of what brain parts are more active and less active. And we cannot, until we do an autopsy, actually establish. So we may see which parts of the brain are affected, but then not in what way. So if it's affected by Lewy bodies, the Alzheimer's, the proteins that come with Alzheimer's, or anything else. So it is very complex. And that's why I think it quite frequently happens for people that they go to a medical doctor, a professional, and they'll get the diagnosis of dementia. And one of the things I always want to highlight is it is not a diagnosis. It is a description of what is happening. But please, from there, do ask the question, what type of dementia do you suspect I or my partner or my parent has? And so they cannot know for sure, but they can at least try to establish with you together, is it more looking like Alzheimer's? Is it looking like vascular? Because it does determine what happens from here. It does determine what you'll be looking at for the future. So getting a diagnosis, receiving that diagnosis of dementia just shouldn't finish the discussion. And this is such a challenge because it is such overwhelming news that people often do go home knowing they have dementia, but not much more than that.
Sure. So there's a very personalized approach that's taken with each patient because there's different types of dementia that they're actually diagnosed with. Definitely makes sense. And I know dementia is a very progressive condition. It can deteriorate over time. In terms of dementia prevention, are there things out there that could help slow down this progression, or anything that can actually prevent dementia itself, or is it always going to be an inevitable condition that someone's diagnosed with?
I'm so glad you're asking this question, Nyrah, because there has been so much progress in recent years. This is not my expertise, but I am willing to share with you that the Lancet, the scientific journal, they shared a commission report. And the first time it was shared, it was in 2017, and then it was updated in 2020. And they describe, the first version was 9, and then it was upgraded to 12 risk factors of dementia, starting from early life, education, through midlife, things like obesity, a lot of heart-related conditions, into later life. And they say this explains 40% of dementia cases, which I, on the one side, am very excited about, but then I look at 60% still being unexplained. And of course, for them also, it is work in progress. They're now studying both sleep and diet. And how that fits into the picture. So there's great work being done. There's a lot of work, and here I'm really going outside my comfort zone, being done on biomarkers as well. So looking in especially the blood to see what there seem to be changes that can be picked up early in life. Same with as within the DNA. But as I said, and this is not my area of expertise, but anyone who's interested in prevention should look up this report. It's quite well written and very helpful, I would say.
Yeah, brilliant. Thank you for sharing that with us. I will keep an eye on the report after the show, actually. It's nice to know that there is research being done, and there'll always be research into the cures and prevention of dementia. And coming towards the topic of actually treating dementia. Now, dementia is a condition that not only affects memory, but it can affect patients, their mood, their behavior. What are the factors actually affect patients going through dementia? What are the complications could dementia lead to?
This is one of my favorite topics, I would say, to zoom in on. You're so right. And again, I think the general picture of dementia, especially Alzheimer's, again, is more about that confusion and how things can become repetitive, which can be challenging for the people around them. But then there's this whole other area of symptoms that may present and that are actually much more challenging to especially the family members. There's frequently described as neuropsychiatric symptoms, or BPSD, behavioral and psychological symptoms of dementia, I've started referring to them as misunderstood behaviors. This is a translation of the Dutch word that's being used, and which for me so more accurately describes what's going on. Because if we speak about BPSD, they kind of become inevitable. You get stuck in this loop of saying, well, why does this person have these symptoms? Because they have dementia. How do I know they have dementia? Because they're displaying these symptoms. Whereas if you start considering them misunderstood behaviors, you're going to start looking at the underlying need. So just to answer your question, I went a little bit off topic there. So these symptoms, they may be agitation, aggression, so it could be verbal, could be physically, being very active, looking for things, hoarding and hiding things, but also more on the withdrawn side. And these people are often overlooked. You know, when you look in a residential home and people are acting out, they get a lot of attention because, you know, it feels disruptive to people. But then there's these people that become more depressed, more anxious, more drawn into themselves, and they often just sit there and are not, because, you know, seems to be no urgent issue for the environment, whereas the person would definitely benefit from support as well.
Definitely. And I actually see in some of the care home visits that I do on a day-to-day basis, there are some patients with dementia that are completely fine to talk to on a day-to-day basis, so that they're happy, they're jolly, no clinical signs of or depression or feeling withdrawn. And, you know, there are other types of patients which are a bit more difficult to have a one-on-one conversation with. In terms of actually taking a more holistic approach when it comes to treatment. Now, I know there are a lot of dementia activity programs out there as well. You know, what are the importance of dementia patients actually still staying active, you know, taking up a hobby or something that they found very exciting and enjoyable early on in their life? You know, how important is that for their current prognosis of dementia?
I would say it's essential. And let me illustrate first with an example that I worked on wards with people with quite advanced dementia. You know, the MMSE, the cognitive functioning, would be close to zero. And there was a man who would move around all the furniture in the living room. And with those beautiful floors, it makes a lot of noise. He would be literally chasing people away who would be seated at the table. He would lift up the chairs, put them on top of the table. Now, if you look at this with that more BPSD kind of cap on, you know, so there's nothing we can do about this. This is just, again, will be considered very disruptive. But one of our staff went up to him and asked him, may I ask what you're doing? And he said, well, I'm preparing my workplace. And we knew he had been a motor and automobile technician, sorry. So he was literally, for him, it made sense what he was doing. It's still for the environment, it doesn't. But what he's telling us is, I do need stimulation, I need activity, I need connection. And I don't know about the situation in the UK. The places I've worked, what unfortunately quite often happens is that in residential homes especially, there is not so much activity, or it's not tailored to the person themselves. So there are group activities, or, you know, the TV is on in the living. I'm just drawing a quite bleak picture here, and I don't mean to disregard all the beautiful work the people are doing. There's just not enough resources, enough staff to make it more personalized. And then if we look at the home, yes?
Sure. No, we are unfortunately coming towards the end of our show. I know that there are so many dementia living tips that we can kind of talk about. I think it would be nice to actually invite you on for another show to talk a bit more about living with dementia alone. I think any other last tips you'd like to include, or I think your Instagram would be great to share before we say goodbye.
That would be great. Thank you very much. I think if you are, or you know someone with dementia, that please do not take on that message that life is over, as it is. find somebody and loved ones and professionals that will support you and that will think outside the box. There's a couple of us out there that will look and be detectives and help you.
Thank you so much, Dr. Eva. There are people out there to listen and to talk to. Now, if you want more information, you can visit NHS Dementia online. See you next week for our next show. Take care.